Good evening, and we're going to wait a couple minutes to let some stragglers enter the live audience. Welcome everybody to the December 2023 edition of Cancer Prevention and Wellness, sponsored by the Cancer Survivors Park Alliance. This is a monthly series that takes place live on the second Thursday of every month from 5:30 to 6:30. All of these sessions are recorded. The Zoom broadcast is recorded and are maintained on the Cancer Survivors Park website, which is Cancer Survivors Park, all one word, all lowercase .org, and look under programs, and you can see all the recorded sessions from prior. And this session from this evening will be on there in a few days. Just as a reminder, you in the live audience will be muted. We do not mean for that to be a case that we don't want to hear from you and don't want to have your questions answered. So if you could do that via the chat feature, and I will be monitoring those, and we'll be asking our presenters as those questions come in. So again, thank you for joining us live. But if you find a lot of value in tonight's series, then please recommend it to people you know and people you think would benefit via the recorded version on our website. So tonight we're joined by a couple of doctors of physical therapy from Bon Secours St. Francis University. It goes on forever, adding names. Mary Tepe is a physical therapist, doctor of physical therapy, a women's care specialist, and Kelsey Nix, also a doctor of physical therapy and a pelvic floor specialist. They've all got board certifications, so they are well equipped to tell you about their trade. And what we're going to be talking about is sexual health throughout the cancer continuum, with real emphasis on some of the things we can do in cancers that have had some surgery, radiation therapy, chemotherapy that deal with tumors that are in the pelvic floor area. And these ladies will describe that anatomy and some of the issues that go along with both the tumors as well as the treatment of the tumors. So without further ado, by the way, I'm Jeff Jagir. I'm your host for this series, but that's really not important. So I'll let you guys take it from here. Thanks so much for being here.
Thank you, Jeff. We are very excited to be here tonight. Pelvic floor is something that we are very interested in and excited about, passionate about. Thank you. Passionate about, and we've both been treating this for a while, and we're happy to just get the word out about our services because we do feel like early referral is really important. And we hope that you learn quite a bit from this presentation and at the end, or at least able to identify too how to get in contact with a pelvic floor therapist. So again, today, really our main goal is to just educate you on our services and how we can be of help. We'd like to just go over some typical pelvic floor related disorders. We will talk a lot about sexual disorders, but we cannot really talk about the pelvic floor without also talking about some bowel and bladder disorders as well. We will spend some time just reviewing the anatomy of the pelvic floor. Most people don't even know these muscles really exist because they're just not talked about as much. And then we'll also go through what a typical assessment might look like from a pelvic floor physical therapist. It can be a little bit intimidating for some people to imagine going to a pelvic floor physical therapist, knowing that there could be another gynecological exam. And then we'll go over a little bit of research related to our interventions, and then just, again, how to identify and find a pelvic floor physical therapist.
So I just remember back in medical school that, when we were doing anatomy, this was, generations ago, this was the most complicated area in the body.
Yeah. You feel really fancy when you can say the names of the pelvic floor.
Oh,
Yeah.
man. Yeah.
Yeah.
Very elaborate.
Yeah. Okay, so at first glance, this slide might just look a little bit discouraging, but I wanted to just emphasize the prevalence of some of these disorders that do exist. These disorders might seem of lesser significance just based on the whole diagnosis of cancer and more of a side effect. But really, these impact one's quality of life and their recovery. And so these are areas that we can help with significantly, and you don't have to live with. Unfortunately, a lot of times these diagnoses or symptoms are also, just not what we talk about at the kitchen table. We hear a lot about our low back pain and hip pain and maybe some nerve irritation, but not a lot about the pelvic floor. Just a couple research points. What did you say?
One of the things that we try to get across to our patients and their caretakers is they have to be their own self-advocate. So
Yeah,
don't think that a symptom or a symptom complex is never going to get better, that it's just something that they have to live with. And obviously it's a difficult, sometimes it's a difficult topic to talk about.
Yeah.
And honestly, I mean, I can speak as a former physician. It's something that's so complicated that maybe I don't encourage their talking about it.
Yeah.
But to have a referral source with expertise like you do will certainly make that conversation go a whole lot better.
Absolutely. Yeah. Yeah. Just lack of awareness about our services is a huge barrier for accessing care in a lot of research articles. Okay, so just some contributing factors to why cancer therapies may contribute to pelvic floor disorders. We'll go through these individually in the next few slides. So number one, just any kind of surgery that one may have can impact, obviously, the tissue integrity. This can cause anything from changes in nerve sensation, whether that's hyperactivity or dampened nerve sensations. It can cause scar tissue, meaning the tissue is a little bit more dense and doesn't move very well. These surgeries can also lead to muscle weakness, depending on where the location of the surgery is, some more than others. And we can help to strengthen these muscles. And it can also reduce even just how the nerves are communicating to some of the muscles, the timing of those contractions. And then some surgeries also can lead to changes in hormonal function. Chemotherapy can contribute to sexual dysfunction in survivors, just regardless of age. Obviously, chemotherapy plays a hard toll on your body, but because it induces a menopausal state and can cause some estrogen deprivation, that can cause changes in the vaginal canal. So it can lead to some narrowing or dryness in the vagina. Labia atrophy, where the tissue might feel a little bit thinner, and some people might feel like some burning sensation present, and that can be very comfortable with attempts for vaginal examination or penetration later on in attempts to participate in sexual intercourse.
You
This can
mentioned
also lead.
one of the complications, Mary and Kelsey, as prolapse. Can you help our audience understand prolapse a little bit better? I know there's different types.
Mhm. Yeah, so there are different types of prolapse, and that is essentially a weakening of the walls between the vagina and the rectum, um, or in the vaginal vault. And so there's kind of a lowering or laxity of that tissue. And so patients might experience some pressure or heaviness in the vaginal canal. And sometimes that can be just a lack of support too from the pelvic floor.
And this can happen even in, without a cancer diagnosis, right?
Correct. Correct.
From childbirth and other things.
Correct.
And one of the surgeries you mentioned was a mastectomy or a lumpectomy. Is that just from a sexual standpoint, arousal and that sort of aspect? Okay.
Yeah, I was thinking more of even just from like a nipple stimulation standpoint too, that can be a large source of arousal. And so that decreased sensation can sometimes lead to difficulty achieving pleasure.
Very good.
Right. This slide is just showing a picture of some of the effects of radiation therapy on the vaginal vault. The one thing I just wanted to point out is vaginal stenosis, which is a narrowing as well as a shortening of the vaginal canal. This can be caused by just scar tissue developing in the vaginal canal. So obviously it can be very limiting for tolerance to penetration. And this is an area that we can help with that we will speak a little bit more about in our later slides.
Can you use your cursor just to kind of,
yeah,
thanks, just to show the before
and there it is. Yeah.
Yeah.
So this is the before here.
Yeah.
You can appreciate the length there, and then the width. And then this is the after.
Okay.
So it can be shorter and more narrow, depending on the type of treatment.
Thank you.
Okay, so going into medications a little bit more, a lot of the medications that you see listed here are used to manage other types of symptoms that may be unrelated to cancer treatment or concurrent with cancer treatment. So antidepressants, antihistamines, anti-nausea medications, androgen deprivation therapy is like a hormone therapy, and all of those can contribute to decreased libido, which if your libido is low, your sex drive is going to be low, and that's definitely going to affect your sexual health and your sexual experience after cancer treatment. Other medications that are common are steroids and antibiotics, and that can weaken the immune system and put you at more risk for like vaginal yeast infections, even sometimes UTIs, and then narcotics. So, I mean, narcotics are things that are used to manage pain all throughout medicine, but a big side effect of narcotics is constipation, and constipation can contribute to pain symptoms, honestly, and even like urinary symptoms as well. So, not that as physical therapists we're managing medications, but we want to know, we want to have the best understanding of what all is going on with you so that we know how to best treat you and advise based on the symptoms that you're experiencing. This next slide here goes into a little bit more in hormonal therapy. So you had mentioned like mastectomies and lumpectomies. So tamoxifen and aromatase inhibitors are often used in breast cancer treatment, but also in gynecological cancers, uterine cancer, ovarian cancer. Tamoxifen is used mostly in premenopausal women, and aromatase inhibitors in postmenopausal women. And basically it helps to block estrogen. estrogen is a really, really important hormone that helps with tissue integrity. So it helps with moisture, it helps with elasticity. And when those things are less after menopause, that can greatly affect the tissue health of the vaginal canal, which can contribute to pain with intercourse, vaginal dryness, irritation, itching, in regards to sexual health, but also urinary and bowel related conditions. So as you can see on this slide, urinary incontinence, POP is pelvic organ prolapse that Mary was just talking about a minute ago. Dyspareunia is just a fancy word for pain with intercourse. And then also like muscle weakness, and constipation. So there's a lot of side effects of many medications that can impact your pelvic health, both urinary, bowel, and sexual function. Other contributing factors, biopsychosocial factors. So we talked a lot about the biological stuff. So hormonal changes specifically in the medications that can contribute to that. Also anatomical changes, especially if surgery is part of your cancer treatment. I think the biggest one to highlight here is psychological. So, you know, a lot of times there have been a lot of things that go on throughout your cancer journey that are going to affect your mood, your self-image, anxiety, depression, and all of that can impact your sexual health, and how you experience life after, you know, your cancer treatment. And so just being aware of these things can be very, very helpful, so that you're able to address different aspects in different ways. So, like we talked about,
one of the things when we were talking about tamoxifen and the aromatase inhibitors,
Mhm.
you know, obviously those are being given for breast cancer as a means of denying the cancer or any residual
Absolutely.
cancer cells, any estrogen. Is there a topical estrogen cream that is appreciated to be not so systemically absorbed as more than others? So
Yes.
you can still use that?
Yes. So there are lots of options. It kind of just depends on your doctor. So the research does not support, well, it does support using topical estrogen locally to the vaginal tissue. But again, of your treating physician, but there are a lot of other options. Hyaluronic acid suppositories, vaginal moisturizers, different things like that that don't have the same estrogen source, and they can be very, very effective for vaginal dryness and just overall tissue health. So physical therapists. So yes, there are physical therapists for this. Otherwise, Mary and I wouldn't be here. So this is kind of an encouraging slide. So women who attended 10 treatment sessions, which I know sounds like a lot, but it's a good amount, which consisted of education, manual therapy, pelvic floor muscle exercises, biofeedback, dilator training, and home exercises, reported being highly satisfied with their treatment, and 90% of them reported improvement. So this is really encouraging because there is a lot of help to be had with physical therapy. I know probably that list of things don't mean a whole lot to you at this point, but they will in a few slides when Mary gets to talk a little bit more about them. But again, there is physical therapy for this. There is help for this. And we want you to know that.
So in talking with these ladies beforehand, they informed me that this subspecialty of physical therapy has been around for 20 years. But from the standpoint of being in our mindset and being readily available, even in Greenville, which is, you know, a pretty big medical community now, you know, it's only been 4 or 5 years that it's really been known and clearly effective and available. And if you're sitting, you know, in other health systems, I mean, there's some private practitioners, but Prisma does not have a capability. I think Spartanburg Regional does. And you'll look at these ladies, they're not the only two at St. Francis. So, you know, if you can't get help within your own health system, then get help someplace.
Yeah, absolutely. And we'll show you where you can find a physical therapist too here at the end.
Right, right.
So what is a PT and what is a pelvic floor PT? So a physical therapist, I'm sure lots of you have been to physical therapy for shoulder pain, knee pain, back pain, and have some sort of understanding of what physical therapy is. Pelvic floor physical therapy is a physical therapist that is trained, has specialty training within the pelvic floor muscles and the conditions related to that. So everybody now in physical therapy, it's a clinical doctorate degree. So you would have a doctor of physical therapy, and then a pelvic floor therapist would have specialized training through one of these options. So Herman and Wallace is a pelvic rehab institute. The American Physical Therapy Association has pelvic health courses specific to specialized training in treating these conditions. There are lots of residency programs throughout the United States. I actually don't know how many, but they provide specialty training in pelvic rehab, and then also board or certifications that therapists can sit for after they've gotten their physical therapy degree to specialize. The scope of practice of a physical therapist, they're really, we're the musculoskeletal and neuromuscular experts. So we are trying to optimize your physical function so that you have a better quality of life and you can get back to doing the things that you love and enjoy without pain or difficulty. We've mentioned a lot of these in previous slides, but I'll kind of run through some other ones maybe that we haven't talked about yet. So a pelvic floor physical therapist is going to evaluate and treat musculoskeletal and neuromuscular dysfunction associated with urinary functions, so urinary incontinence or urinary leakage, urinary urgency, frequency, even pain with urination, bowel dysfunction, so that may be constipation or fecal incontinence, or even what's called dysenergic defecation. And so that's a lot of times just like struggling to have a bowel movement. Sexual function, so that may be pain with intercourse, that may be inability or difficulty orgasming, or even for men, erectile dysfunction, pelvic and abdominal pain disorders, pelvic organ prolapse, again, like we talked about earlier, and then even breast and prostate cancer management. So we at Bon Secours actually have a oncology therapist that specializes in breast health treatment. So she gets to see a lot of those patients, and then we see a lot of the patients with prostate cancer or after prostate cancer treatment.
So you mentioned men's sexual health. What kind of things do you get men referred to you for?
A lot of the same thing that we get women referred for. So urinary leakage, constipation, pelvic pain. Again, a lot of the men that we see may be undergoing a prostatectomy for prostate cancer. Anything else you can think of? That's about it. Yeah. So very similar things. I think
So
we don't
just
talk
from-
about them a lot as women. We talk about them even a lot less as
Yeah,
men.
just from the standpoint to the men out there or ladies that are listening to you, the people that you love and influence, you know, that this option is available for not just the female.
Absolutely. Yep. All right, so I'm gonna grab this model here. We'll see. Okay, so your pelvic floor, you might be wondering, like, what is your pelvic floor? I have no idea what you're talking about. So your pelvic floor is this group of muscles that sit at the bottom of your pelvis and your abdominal cavity. So they run from the front of your pubic bone to your tailbone, back here in the back, kind of like a hammock or a bowl, okay? Those pelvic floor muscles, so we call it the pelvic floor as a group of muscles, but really it's made up of a bunch of individual muscles. So you can see here on the slide, you know, here's a muscle, here's a muscle, here's a muscle. They all have different names. But together they work together as a group or as a team. So there are 3 layers of pelvic floor muscles. We have this outer layer, which again, you can see right here on the screen. We have this middle pelvic floor layer, which kind of sits right under that first layer. And then we have this deep pelvic floor layer, which is called the levator ani group. And so all of those muscles kind of just, you can think of them as like sitting like stacking bowls. So the pelvic floor muscles work together for a few different functions. So the first function is to create support for the pelvis and the pelvic organs. So when we look inside of the pelvis here, it's going to be easier to see than on this model. We have the pubic bone here in the front. We have the tailbone here in the back. We have the bladder, the uterus, and the vaginal canal, and then the rectum, okay? And then right here, this little sling here is your pelvic floor. So the pelvic floor muscles help to keep all of those pelvic organs up and inside of the body where they belong. Other fascial and ligamentous attachments within the pelvic cavity also help to suspend the organs to help with support. So the interesting thing here is you have a lot of support structures. They work differently. So pelvic floor muscles are voluntary muscles, meaning you can contract and relax them, just like the muscles in your arms and your legs. But we also have fascia and ligaments, which you can't really, unfortunately, see in this picture, but they're helping to suspend the organs, and those are non-contractile tissue. And so oftentimes that tissue can be affected, again, with radiation treatment, and then other cancer treatments and medications. The second function of the pelvic floor muscles is as part of your core. So a lot of times people just kind of think of this abdominal wall here as your core, right? Anytime we do core exercises, we're doing all the crunches, but we want to think more of like a canister. So we've got your abdominal wall in the front. We have your pelvic floor on the bottom. We have your back or your multifidus muscles back here along the spine. And then we also have your breathing diaphragm. So all 4 of those muscle groups make up your core and help to stabilize your spine and your pelvis with movements. That's really, really important for pressure management. Excuse me. For pressure management, when we're moving, when we're lifting, when we're coughing, when we're laughing, sneezing, so that we're not leaking urine or we're not leaking stool or things aren't falling out the bottom. And so that is a major role of your pelvic floor that can really be improved with physical therapy.
You're just demonstrating the cough.
Yes.
Yeah, that's really well done.
The other functions of the pelvic floor muscles are, that's okay. The sphincteric function. So this is what most of us think of when we think of the pelvic floor. So they wrap around the opening of the urethra and the rectum, and they create closure to hold back. And then they also relax and let go to empty. So it's really important that those muscles move through that full range of motion so that you're able to hold back, but you also can let go. And then last but not least is the sexual function. So those pelvic floor muscles attach, you can kind of see that superficial layer, especially attaches here at the hood of the clitoris, and blood flow and muscle contraction helps with sexual arousal and pleasure. And so having that, those muscles having that ability to contract and let go is going to help with orgasm and pleasure.
Okay, oops, excuse me. Okay, so what does a pelvic floor muscle assessment entail, and what should you expect when you arrive and go to a pelvic floor physical therapist? So the big expectation is to know that we do a internal examination if possible. That gives us the best information about your pelvic floor muscles, because these muscles are so deep, we can't always feel exactly what's going on just looking from the outside. And so with that examination, we're looking at, number one, just the reflexive behavior of your muscles. So as Kelsey was coughing just a few minutes ago, the proper reflex would be that your muscles should contract in the pelvic floor to reduce pressure or load on the bladder to prevent leaking from happening. So that is one thing that we might ask for. We're also assessing the muscles for pain. So those lovely muscles that Kelsey was pointing at, we are able to palpate and press on just to see if we elicit any discomfort, as these muscles also can refer to other areas of the body, including the abdomen and the hips. And so we're really looking for, are there any outside areas that might be uncomfortable, as well as any pain locally. We're also assessing for tissue integrity. So we're kind of feeling what that tissue, how it's kind of stretches, or if it's dense or fibrotic, if it's high tone, which is kind of more of an overactive type muscle, or maybe that it feels a little boggy and we need to work a little bit on strengthening. And then we're also looking at the coordination of your pelvic floor. So this is really, really important. Research shows that actually about 40% of women who have gone to a physical therapist to have an assessment of their pelvic floor and thought that they could Kegel, which is a pelvic floor contraction, correctly, were unable to. And so what we see with that is often people are compensating in some way. Maybe they're tightening up the bottom, or they're holding their breath, or they're squeezing their inner thighs, but they're really not isolating a contraction well. So again, going back to those main functions that Kelsey mentioned, if you're unable to contract or isolate the muscles well, maybe you will have difficulty with that pleasure or orgasm because you're not producing a good contraction, or you might have leakage, again, because you're not getting great sphincteric closure. So we're looking at the ability to kind of isolate a contraction. We're also looking at how the pelvic floor muscles relax. So another kind of misconception about pelvic floor PT is that we only do Kegel exercises, and that is very incorrect. Actually, probably more commonly, we're working on getting the muscles to relax and lengthen to allow for, maybe it's penetration, or it could be to evacuate, to have a bowel movement, or it could be even to urinate. So some people might come in with some kind of what they're feeling like urinary retention problems. And then we're also looking at, kind of going alongside with that, just the ability to bear down or bulge, to properly coordinate the muscles to have a bowel movement. Sometimes we find that patients are actually tensing or contracting the muscles versus relaxing when they're trying to evacuate. And so that can lead to a backup and obviously cause a lot of discomfort. And then finally, we're also looking at how the diaphragm and the pelvic floor move together. So your diaphragm is this big respiratory muscle here at the top, and your diaphragm and your pelvic floor move together. So as you inhale, the diaphragm pushes down, and then actually your pelvic floor should move down with it as well. And then as you exhale, the diaphragm lifts up, and then the pelvic floor also lifts up at the same time. And so we have found that you can use, actually just teaching people to breathe differently using their diaphragm can really impact pelvic floor function. It can reduce pain. There's a lot of research to support its ability to also calm the nervous system down, which can be extremely beneficial with maybe that first time getting back into trying to participate in sexual intercourse. Going on a little bit further into our exam, if we're testing the strength or endurance of the muscles, again, we're just looking for kind of squeeze pressure around the vaginal canal with a contraction and how long you're able to hold that contraction. We also feel it's very important to take a look at how the abdomen is moving and if there are any incisions that might be present, which can impact how this abdominal muscle called the transverse abdominis is working, as it is a muscle that really works together with the pelvic floor. So if that muscle fatigues, sometimes we're able to teach the transverse abdominis to kind of help out the pelvic floor a little bit. We just talked a little bit about the breathing mechanics. And then just generally as physical therapists, we're always looking at someone's posture and how that might impact day-to-day symptoms. So an example might be someone that's gone through maybe a mastectomy, could have more of a kind of forward-leaning posture. And so that might be being self-conscious or even just having some tissue fibrosis present. And what that does in that forward place posture is that it can put more pressure on your pelvic floor muscles and those organs. And so sometimes the pelvic floor gets a little bit fatigued or can also develop pain patterns. We take a look at everyone's body mechanics, and that is really specific to what patients' goals are too. So maybe you come to us with, I'm having leakage with trying to get back into gardening or doing yard work. We want to look at how you're doing that activity and how we can teach you to do it better and utilizing your muscles more efficiently so you're not experiencing pain or leakage. And then finally, we're looking at how your joints move and any muscle tension patterns that you might have. We'll always ask about previous injuries, if you have had a history of back or hip pain. Those really highly correlate also to pelvic floor dysfunction. After the assessment, these categories are not black and white, but we typically end up having patients that are either on have a kind of an underactive pelvic floor, which means that we might focus a little bit more on strengthening the muscles and trying to increase awareness and sensation to those muscles. They might have more of what we call an overactive pelvic floor, which is one that we often see with patients that have pain with intercourse or difficulty allowing penetration. Maybe they've gone through a fair amount of trauma in their pelvis, or the muscles have experienced some trauma. And so we would be working more on relaxation. And then a coordination deficit is more when the muscles are just not doing, that maybe they're contracting the muscles versus relaxing when they should be doing the opposite. Now into some more fun stuff for us. In terms of treatment, the first thing that we really focus on in physical therapy is a big fancy word called neuromuscular re-education. And so what that really means is that we are trying to retrain how the nerves and muscles are communicating. And so again, that can look a little bit different depending on the patient's assessment and what their goals are. So we have some different tools to help with training the muscles. The best tool we really have is actually this. And so really just tactile cueing and providing feedback in the vaginal canal can be a really powerful tool to help patients feel or be able to learn to isolate either a contraction or feeling the muscles relax. We also have what's called biofeedback, and this is really, really cool. Biofeedback's been around for a while, but it's probably not as talked about for the pelvic floor. So biofeedback is a way that we can look at what your pelvic floor muscles are doing using external electrodes. And so these are placed as close to the pelvic floor as we can get. So that would be actually perianally. And these don't zap you or anything like that. They just give us output. And so on the computer, you can see your muscles when they're contracting versus relaxing. And so this can be a really great tool for the clinician and the patient, because it can give patients a nice visual of the muscles. What we find often is that when we're training the pelvic floor, it's just more it's a little bit trickier, because when you're trying to strengthen your bicep muscle, we can kind of watch your muscles contracting and relaxing. In the pelvic floor, that's much harder to do. And so we can use this as a tool to help patients have better confidence with that, both on the strengthening side, but also on the relaxation side. So subconsciously, the pelvic floor muscles sometimes are actually a little bit more tense and overactive, because they have had discomfort, or maybe you've had an episode of painful intercourse, and so your body remembers that experience and kind of guards and retracts versus relaxes to allow for penetration and friction to occur. E-stim is just a tool that uses kind of a vibratory signal to help stimulate a muscle contraction. I do want to point out, this is not something we would use on a patient that has vaginal atrophy, just because it wouldn't be the tissue integrity, it would not be as comfortable. But if it's just a pure kind of weakness case, then we could potentially use that. And then functional retraining. So after we've really taught the muscles or created better awareness for the patient as to how to coordinate the pelvic floor muscles, we're implementing that into function. So again, how do we use those muscles during the activities or your goals that you would like to get back to doing? Manual therapy, again, our biggest treatment strategy with this is also a digit can really be helpful for this, just to help release the pelvic floor muscles and work out any tension or tightness in the pelvic floor. So we can do this through the intravaginal canal or intrarectally, and this can help to break down scar tissue and help create good range of motion in that pelvic floor to kind of open things up. Connective tissue manipulation, again, is kind of a fancy word for a massage technique, but it's been around for a long time. I think just we don't think about it in this area, obviously. Dilator training is really, really helpful, and something that can be quite intimidating for people. But this is a tool that can, or these are tools, I should say, that can help women trying to reach their goal to get back to participation in intercourse. Dilators are these cylindrical tools here at the bottom. And so they increase in both length and width. And so they allow to increase range of motion and tissue compliance at a kind of slower rate. And so this is something that can be really helpful for patients to use at home to prevent scarring from happening, and then also to give confidence to be able to return to allowing for vaginal penetration and getting back to intercourse. And we kind of touched on the lubricants and moisturizers too. We would always pair with using the dilators. And then finally, we will always go through some strengthening as well for the muscles that support your pelvic floor. So the pelvic floor does not work by itself. It's connected to several other areas of your body. So we want to make sure that we're treating your whole body and not just the pelvis. So we also recognize that different medications and maybe a period of immobility may have been present during your treatment. And so our goal, again, is to get you back to the strength that you once had and build the muscles that really need to be worked on the most. So not just your pelvic floor, but the hips and the back and the abdominal muscles as well. This may also consist of, go ahead.
Yeah, I suspect that you're retraining the muscles, you're breaking down scar tissue. You have a lot of I thought the biofeedback capabilities were really, really interesting. But I imagine that a lot of these patients come with body image, how they're dealing with their partner. They're trying to do what they used to do, like you mentioned, gardening or just living, and they're having incontinence and that. I just wonder, do you have any training or anything that you're help them with the psychosocial overlay of all these issues? Because they're really dynamic. I mean, that the pelvis, along with all the muscles, it's got a lot of nerves. I mean, it can be a lot of pain and that sort of thing. So just wonder how you dealt with that dynamic.
Yeah. I mean, I think the best thing we can do is just make sure that we're always on the same page with what their goals are, because our goals as PTs may not be the patient's goals. And so, we want that to be number one. Maybe it's also bringing in the patient, a patient's partner too, to talk through some of these issues and come up with some strategies together to help address the problem. Because we know that, you're not in this alone too. And then of course we would probably recommend, if needed, counseling services too, to pull in to help with any of those other areas if need be.
Right.
Yeah.
So if you're sitting here thinking, like, that sounds like something maybe I could benefit from. Survivors of gynecological cancer often don't seek treatment, as they report that their symptoms pale in comparison to what they recently experienced with their cancer diagnosis. So like Mary kind of said at the beginning, a lot of times these things that people experience after treatment just seem like, oh, it's a little bit of urinary leakage. I'm not a big deal about that. Oh, well, pain's always going to, or sex is always going to be painful. There's help. And a lot of times people don't seek help because they're not aware that there is treatment for it. And so again, we're here just to let you know that there is help, even after cancer treatment. And again, a lot of people have a lot of really good success. Like we had mentioned kind of earlier, if the sooner you can get sent to physical therapy, just like anything, right? The sooner you can get help for your knee pain, the sooner it's going to get better. And so the same thing for pelvic related conditions. The earlier that you can get sent to a pelvic floor therapist, it's going to help to improve compliance and your outcomes, which is going to help you get better and feel better and be able to do the things that you want to do faster. This slide here kind of talks a little bit about like resources, places that you can go to find a pelvic floor physical therapist. So the American Physical Therapy Association and Herman and Wallace both have directories for pelvic floor physical therapists. If you're not in Greenville, we do fortunately have a lot of options between the health systems and private practices. But if you're not in this area or you know somebody that might benefit from pelvic floor physical therapy, these are two great websites to search, your zip code. The Pelvic Global Academy is also a great directory. There are a lot of pelvic floor physical therapists on there, but this directory is also it's pelvic rehab providers. So it may be a medical doctor, it may be a nurse practitioner, it may be a sex counselor, it may be a pelvic floor physical therapist. So it's also a great resource. And here at Bon Secours, we have 6 pelvic floor physical therapists between our 2 locations. Our location at Eastside Hospital in the outpatient facility, and then also at the Millennium campus across from the Cancer Center off of Lawrence Road. So we have lots of people that can help you if that's what you need. And that's all we got.
That is great, guys. You've either been really all inclusive and very clear because I have no questions, or They're just overwhelmed by all that anatomy and
It's
whatnot.
a lot of information.
But just kind of from the standpoint of the one aspect of Cancer Survivors Park and what we're trying to do programmatically is make sure that people are aware that some of their symptoms, some of their symptom complexes do have fixes, and they don't
Yeah.
have to live with the issues. And if you could just kind of emphasize the diagnoses, the symptoms that you feel like you could help with the emphasis, and I'm emphasizing it, that earlier referral, getting to you guys earlier is better than later, because you have more of a situation that's hard to reverse.
Absolutely. Yeah, absolutely. So yeah, the sooner the better.
But some of
Mary
the
kind of talked.
diagnoses that you think that people maybe have just said, I'm going to live with this.
Yeah, so pain with intercourse, definitely.
Yeah.
Especially after gynecological cancer. So a lot of times that tissue can get restricted and bound down. And so if we can keep that open and open it up faster and keep it open, then that can really, really benefit urinary leakage, constipation, urinary frequency, incomplete bladder emptying,
You ever have a
vaginal
situation
pressure.
where somebody's, had a catheter for a urinary catheter for a while and just can't seem to get the catheter out, and you can help them in that regard?
Oh, we don't, I mean, you mean in terms of like a muscle's
Yeah,
not relaxing well?
yeah. I don't know. I just, from the standpoint of general medicine, whether or not that's something you've seen before or dealt with, doesn't sound like it.
Yeah, we've seen a lot of pain following having a
Yeah.
catheter in place for an extended period of time.
Okay.
Definitely. We have seen some urinary like hesitancy or retention problems as well. It could be related to that too.
Yeah.
Some muscle guarding.
Well, great, guys. Let me just check the chat. And again, no questions. Dr. Tepe, Dr. Nix, thank you.
Thank
Kelsey,
you.
Mary, this kind of completes our 2023 series. We already have the calendar full for the 2024 series, and that will be available via resources at your health system that you're working with, and will be on the Cancer Survivors Park website as well. Our January speaker on January 11th is Dr. Cassidy Hood, who's a family practitioner, physician, and board certified in the American College of Lifestyle Medicine. And just from the standpoint of lifestyle changes and ways to live that can help kind of reverse the issue of chronic disease, chronic inflammation. Certainly, it's a good way to live in the post-cancer survivorship area. So very interested in what she has to say. So kind of mark that down on your calendars. If you really enjoyed today's lecture, which I certainly did and learned a lot, then please pass that information. Word of mouth is great. They can refer back to the website, and we can see this recorded version in a few days. So as usually is my pattern, I have a few quotes, and it is the holiday season, but we also have the New Year coming up. And these are two quotes from The Little Prince by Antoine de Saint-Exupéry, and this is kind of our New Year's resolution quote. It is madness to hate all roses because you got scratched with one thorn, to give up on your dreams because one didn't come true, to lose faith in prayers because one was not answered, to give up, this is a doctor's handwriting, to give up on our efforts because one of them failed, to condemn all your friends because one betrayed you, not to believe in love because someone was unfaithful or didn't love you back, to throw away all your chances to be happy because you didn't succeed on the first attempt. I hope that as you go on your way, You don't give in or give up. And for more of the Christmas thing, there's a quote from this Little Prince. All grown-ups were once children, but only a few of them remember it. So during this holiday season, try to remember that you were a kid once. And thank you. And we'll sign off. Thank you.
Thank you.
Yeah.